So the March MEC minute is going to be on guidelines for pre-hospital pain management. And the discussion really is focused on this article that was electronically published in Pre-Hospital Emergency Care regarding guidelines for pre-hospital pain management. And this is actually a group of experts in pre-hospital care, and they were posed some questions to be answered regarding pre-hospital pain and how we should manage it. So why are we going to talk about this? Well, pain is one of our most common patient complaints. So regardless of the reason for the call, many of the calls have something to do with pain. And if you look at studies that are out there, between 34 and 42% of EMS patients report some type of acute pain as part of their reason for calling. And for those patients who have pain, up to 64% of the patients say the pain is severe. I think as EMS providers, we should be aware of pain management options that are available to us and that are well within our scope of practice. And I also think it's important for EMS providers to understand why we do what we do. What is the rationale behind the protocol or the reason to give this medication? I don't think we just technicians who say, okay, you have this problem, let's do this for you. I think you need to have some understanding of why we do what we do, so you can respond to the patients if they ask questions, and so you have some basic understanding of the practice that you have. Just some opening comments about this. If you look at the article, it was a panel of EMS experts, and they were asked 10 questions on behalf of the Agency for Healthcare Research and Quality. AHRQ is a federal entity that assembles best practices and guidelines for the care of patients. And it really covers the broad spectrum of medicine, whether it has to do with orthopedics, infectious disease, or in our case, EMS and pre-hospital care and pre-hospital care of pain management. All of the questions that were posed as part of this article involved best ways to manage moderate to severe pain. So mild pain really wasn't part of the equation, because if you look at the questions, most of them have to do with parenteral medications, and typically we don't give intravenous, intramuscular, intranasal medications for pain that is mild. And for a reasonable number of these questions that were asked, the amount of comparative data was low. So if they ask a question of compare this drug versus that drug for EMS management of pain, some of the questions they respond with, here's what we think is best practice or is a good recommendation, but the level of evidence to support a recommendation is really not what we would want it to be. But here's our answer anyway. And when I looked at this article, I also considered this article, which came out last year, and I think we've talked about before, and that has to do with ketamine use in pre-hospital care for the acute trauma patient. And I refer to this as well because a reasonable number of the questions that are being asked have something to do with ketamine. And ketamine for us has become one of our go-to drugs for pain management. So I mentioned there were 10 questions. Well, what were they? Well, here they are. And I'm just going to kind of go through them relatively quickly. And as I get to each slide, I'll kind of give you the summary question. First has to do with, should we use intranasal fentanyl versus IV drugs, IV opioids for pain in children? Second question, should we use IV acetaminophen as an alternative to IV opioids for moderate to severe pain in the pre-hospital setting? The third question has to do with the use of non-steroidal anti-inflammatories or NSAIDs versus IV opioids. The one that we would use in the field as an injectable non-steroidal is Toradol, which I think everybody has heard of in the past. The fourth question is, should we use IV acetaminophen or should we use IV non-steroidals for the treatment of moderate to severe pain in the pre-hospital setting? So if you have IV acetaminophen versus IV Toradol, it should use one over the other. The fifth one has to do with ketamine. It's one of several. Should we use IV ketamine rather than IV Toradol for the moderate to severe pain in the pre-hospital setting? The sixth question is, should we use IV ketamine versus IV opioids? And for us, that means fentanyl for moderate to severe pain. In other words, which one is there research to say one might be better than the other? The seventh question is, should we use IV morphine or IV fentanyl for the treatment of moderate to severe pain? We've moved away from morphine more than 5 years ago. I think we've had good success with fentanyl, and I'll have some comments about this question when I get to it. Should we use a combination of weight-based IV opioids plus ketamine, or just IV opioids on a weight-based basis for treatment of moderate to severe pain in the pre-hospital setting. That basically is a question of, it's the initial drug. If a patient has pain, should we give them immediately IV ketamine and opioids, or just IV opioids if the patient has acute pain and we're going to give them medication at this moment in time? It's not a question about should we add one after the other if one is unsuccessful. The ninth question is really that answers that question: should a combination of IV opioids plus ketamine be used versus IV ketamine alone? This recognizes that ketamine by itself can be good to use for pain management. Should we use both of them, or should we just use ketamine by itself? And the last one has to do with nitrous oxide. Should we use nitrous for rather than IV opioids for the treatment of moderate to severe pain in the pre-hospital setting? So those are the 10 questions. So here's the first one. It has to do with intranasal versus IV fentanyl, and the recommendation is that we administer intranasal fentanyl rather than intramuscular or intravenous fentanyl or opioids for moderate to severe pain in pediatric populations, and this is prior to IV access. They recommend intranasal over IM or IV opioids in a pediatric patient who has no IV access. They say once you've got IV access, there's a conditional recommendation that you could continue to use intranasal if you want, or you could use IV opioids. I think most of us would say, if you have IV access, use the IV. But I think, for me, my comment for this is, it makes sense to use intranasal fentanyl in children who have an acute emergent condition and need immediate pain control. We all know it can take a little bit more time to get an IV started in kids, and I think most of us can recall at least one or more children we've treated that's had an acute orthopedic injury, and we give them intranasal fentanyl, and within 5 minutes the child is much more comfortable, which makes for an easier transport. So keep in mind, the recommendation is if we can give intranasal fentanyl, do it. Once we get IV access in a child, we can go either with intranasal or IV. My preference would be once IV is established, use it IV. We can do a better job titrating to effective IV. Second question, IV acetaminophen versus IV fentanyl. This expert panel voted in favor of IV acetaminophen rather than IV opioids. And again, opioids to me is fentanyl. For the initial management of moderate severe pain, if IV acetaminophen is available, affordable, and easy to administer. Well, I think, my comment is it's a good idea, but IV acetaminophen is $30 per dose, and this is our cost through Boundtree, so this is after our Boundtree discount. And that is 11 times more expensive than fentanyl, so it's $30 versus $2.50. I can tell you at the hospital, I have no access to IV acetaminophen. Mount Carmel's decided it's too expensive to make it as a drug that's available for us to use in the emergency department. So IV acetaminophen is a good drug. The few occasions I've been able to use it, I've had good success with it. It is safer in terms of it's less likely to cause hypotension or sedation, but it is extremely expensive. And I think for most of us, when we look at the cost versus the benefit, we can't justify that extra $27.50 to get a dose of IV acetaminophen into a patient. I think it also has to be infused, which means it takes longer to administer than a dose of IV fentanyl, which you can give as a quick bolus. The third question has to do with IV Toradol versus IV fentanyl. And really, they're kind of neutral on this. They say we can use either IV non-steroidals, IV Toradol, or IV fentanyl as the initial management for moderate to severe pain. From my perspective, as a comment, there does not appear to be any significant difference in efficacy. From my clinical experience, IV Toradol is a good drug for patients who have not had narcotics in the past. For the patients who are used to getting IV or used to narcotics for pain management, for whatever the cause of the pain is, they're less likely to be helped by Toradol. Whereas for the opioid naive patient, the patient's not had narcotics before, Toradol works well. The costs are about the same. They're both around $3 a dose. Toradol, however, can increase bleeding in surgical patients. I know my surgeons don't like patients to receive Toradol if they go to the OR. My urologists will delay taking patients to surgery for kidney stones if they've received IV Toradol because they think it increases the bleeding risk. So if we ever started to use Toradol in the field, I think our suggestion would probably be if you think you've got a surgical patient who's going to require surgery to have a surgical complaint, probably use something other than Toradol. The fourth question has to do with IV acetaminophen versus IV Toradol. In this case, they suggest IV Toradol over IV acetaminophen. This is primarily an opinion based on the cost of IV acetaminophen versus IV Toradol. They're seen as having really kind of comparable efficacy in managing pain, but when you have one drug that costs about 9 times more than the other, we tend to go to the cheaper drug, which would be the IV Toradol. They also recommend in favor of either oral nonsteroidals. For us, that would be ibuprofen, or oral acetaminophen for the initial management of pain, if you think the patient can take an oral analgesic. And this current recommendation is all relatively low evidence, level of evidence. So this recommendation is more a recommendation based on some data, but also based on a consideration of the cost of one medicine versus the other, and some professional clinical experience. So my comments: IV Toradol is about 9 times less expensive than acetaminophen, and also PO meds is way cheaper. So a PO dose of ibuprofen or acetaminophen we're talking about less than $1 versus IV Toradol $3.25 and IV acetaminophen at $30. I think we could make more of an effort to provide PO medication for pain in the field, particularly for patients who have pain that's relatively low in intensity, and they really need an injection of medication. So for me, an example there would be, we have a patient, they twisted their ankle, there's no significant deformity, the joint is not unstable, they have a bit of a limp. You could give them a dose of ibuprofen in the field, and you probably get them on the way to getting pain control 30 minutes ahead of the emergency department giving it to them on arrival. So I think probably in the future, one of the things we could do is focus a little bit more on using oral medications for pain control for patients with mild to moderate pain. More to come on that one. The fifth question has to do with IV ketamine versus IV Toradol. And again, they basically say we see them as equivalent. We suggest either IV ketamine or IV nonsteroidals, IV Toradol, for the initial management of moderate to severe pain. So if you have no fentanyl, you have ketamine or Toradol, they see them as being equally effective. From my perspective, they're equally effective, but we really need another medication on the truck. We already have ketamine, we already have fentanyl. How much advantage is there to getting IV Toradol on the truck? It's just another thing we have to stock. Over the years, we've spent a lot of time focusing on reducing the amount of drugs we carry. Do we need to really increase the number of drugs on a truck? The sixth question, IV ketamine versus IV fentanyl. They suggest either IV ketamine or IV opioids, IV fentanyl for the initial management of moderate to severe pain. So this is us. We have ketamine, we have fentanyl. We already have a drug treatment algorithm or a pain treatment algorithm that says you can use either of these drugs as a primary IV medication. Pick one. If you have a patient who's having severe pain, they're already on narcotics, maybe ketamine might be the drug to use. But we already have both options available. As this expert panel says, either of these drugs as the first drug to be given are equally effective. And honestly, from a cost perspective, they cost about the same. I mean, the cost between these drugs, two drugs, is maybe, I don't know, a couple dollars at the most. So we already have these drugs. I think this is us right here. You pick a drug, get that which you're comfortable with, and use it. How about IV morphine versus IV fentanyl? So, in years past, we've had morphine on the trucks. We went to fentanyl because, at least I thought, that fentanyl for EMS purposes was a better of the choices. And I think when we made that decision, the literature supported changing the fentanyl. If you compare one versus the other, this expert panel says they're equal. We suggest one or the other for moderate to severe pain in the pre-hospital setting. From my perspective, morphine takes longer to work. It's more likely to cause nausea, more likely to cause histamine release. Histamine is what causes hives. It's what causes angioedema. It's what can cause hypotension. So I think fentanyl has a safer or a better safety profile, particularly if you're looking at potential risk for hypotension. And I think it works faster. Fentanyl can be used and can be titrated in the field. And I think you do that more effectively. When you have morphine, it has a longer half-life, but takes 20 minutes to show its peak effect, versus fentanyl, which has peak effect in 5 minutes. I think for what we do, fentanyl is a better drug. It works faster. It's got a better safety profile, and we can titrate it in the field if we need to give more. That's my prejudice for fentanyl and against morphine, even though from a pain management perspective, they may be equally effective. There's another question. I thought this was kind of a weird one. So this is, weight-based ketamine plus fentanyl versus fentanyl alone, and this is for the initial management of pain. So this is a question that basically says, should we calculate doses of fentanyl and ketamine and give ketamine plus fentanyl at the same time for this initial episode of pain management, or should we just use fentanyl alone? This group kind of voted like I would vote. They're voting against the combination of IV fentanyl plus ketamine at the same time for managing acute pain. And when I say same time, I mean you have patient in pain, you're going to give them medicine, and then what medicine are you going to give them? Not did you give them medicine, it didn't work, do you give them more, or do you give them a different drug? So this is saying, okay, we're going to give you a bolus of both ketamine and fentanyl at the same time. And I would agree with their recommendation. I think we should avoid just giving the patient a mixed combination of drugs. I think we should pick one, whether you want to use ketamine or you want to use fentanyl. Both are covered by protocol. Titrate it to effect. Think about maxing out on whichever one you pick, and then if the first medication doesn't give adequate relief, go to the second medication. So, fentanyl and ketamine at one time, you give it as a big slug, that is much more likely to result in respiratory depression. That's something we would like to avoid. So I think prudence is you pick a drug, whether it's fentanyl or ketamine, you give it to the patient. If you're able to give a second dose because the patient needs it, do that. Once you've maxed out on one drug, you can add the other drug. So think about doing that. The next question has to do with really, should we give IV ketamine and fentanyl or IV ketamine alone? So the question number 9 had to do ketamine and fentanyl versus fentanyl. This is ketamine plus fentanyl versus ketamine. And again, in this circumstance, they said there's really not adequate information to make a comment on this or to make a recommendation. So they're not going to make a recommendation on this one. Again, from my perspective, pick one drug, use a stepwise progression of drug dosing, follow the algorithm, and keep the patient safe. My concern is if we give the patient a combination of ketamine and fentanyl at one time, they're much more likely to have adverse effects such as respiratory depression. We can always add more medication and help the patient that way. The final question has to do with nitrous versus IV fentanyl. They have no recommendation regarding comparing one versus the other. Just from my perspective, nitrous does help control pain, but I don't see a big added benefit. We have other ways of managing pain in the field. We can give intranasal medications. We can give intramuscular ketamine as part of our pain control program. So, we have other options. And just like IV acetaminophen or IV Toradol, do we really need another medication on the truck? At this point, my vote would be no. And I think, I don't have any experience with nitrous recently in terms of what we have in our stations and what resources are available. But my experience is that the nitrous we had on our trucks was used more in the bay by the EMS providers doing equipment checks and for a little fun on the floor than for actual patient care. So I really don't see a big value in having nitrous made available. If you're talking about somebody who may need a little sedation, they're a little uncomfortable, we have various ways to do that between our pain meds and use of midazolam if the patient seems anxious. So I don't see big value with nitrous, so I am in agreement with them. So if we look at all this, what's the summary recommendations? These are my recommendations. This is my summary. I think the first thing has use intranasal fentanyl in children. It works well. You can titrate it. You give another dose if you need it, and the parents will love you. I've heard several compliments from parents regarding EMS providers because of their administration of intranasal fentanyl to children who have suffered an injury. Usually it's an orthopedic injury with obvious fracture and deformity. It works well. Second recommendation is intravenous acetaminophen or intravenous Tylenol or APAP, however you want to call it. It works well, but it is very expensive. And its cost really does not justify adding it to the medication list. I don't see any significant incremental increase in value by having this medication on our truck. It just costs too much money. Toradol works well, but again, like acetaminophen, it doesn't bring any added value when compared to fentanyl or ketamine. Do we really need to add another medication to the truck? Plus, it may increase the bleeding risk in our surgical patients. So I at this point don't see any value to adding Toradol to the truck. If you as providers see that there's a potential benefit, feel free to reach out. We can consider it. We can talk about it. It could be something we added to the 2023 protocol if there's enough interest and enough justification to adding it to the truck. Morphine, I don't think we currently need morphine. We've had it on the trucks, and we took it off because fentanyl was seen as a better medication. Fentanyl has a better safety profile as far as I'm concerned. It works faster. It's easier to titrate in the field. If a patient needs more, we can give them more. If we had a patient with pain and we gave them morphine, we would have to probably wait 15 to 20 minutes before we can redose the patient. So I don't see the immediate need to think about adding morphine. If we ever got to a circumstance where we had long transport times, we can think about it. Morphine, if we have an hour and a half transport time, I could see value of morphine because it can keep the patient comfortable for a longer period of time. So right now, I don't see morphine as a need. Morphine is our backup drug if fentanyl ever became short supply. So if you look at our drug licenses, morphine is on it, but it's only because it's a backup drug if we were to lose our supply of fentanyl. In the field for patients in acute pain, as our protocols listed, you can use either ketamine or fentanyl. Pick one, dose it, and then titrate to maximal effect or until you reach the limit that you can administer. If that's inadequate, then you can add the other drug. So I think that is a more prudent way to go. And it's also what it was recommended as part of that review of ketamine and use in trauma that I first mentioned at the beginning of the talk. So start with one, use it to maximal effect, add the other. Nitrous, like IV acetaminophen, has a little to add, but adds to the medication cost. I've not heard anybody recently ask about nitrous or identified a need for it, but we could add it if we think we need it. But I think it adds cost, and I think it's more likely to be abused than the other medications because it's harder to secure. One thing that's not covered in this review: what is the role of intramuscular ketamine for pain? So it was not mentioned in this review. It was mentioned in that review regarding ketamine use in trauma patients. Intramuscular ketamine works. We have it set up so that you give a dose intramuscularly. There's a maximum dose identified. I have had patients come into the trauma bay, no IV access because they have lousy veins. They are very uncomfortable because of an acute injury. We give them a dose of intramuscular ketamine, and in 5 minutes they're comfortable. We can take our time to get IV access started, and we can further assess the patient. So always think about using ketamine for pain. If you have a patient in the middle of a field, they have a significant orthopedic injury, or they're in a car and you need to extricate them, intramuscular ketamine works well. The only concern I would have with IM ketamine is make sure that you have access to the airway so that if the patient has any respiratory depression after the IM ketamine, you can manage the airway if indicated. So think about IM ketamine. Again, it wasn't part of this review, but I think it works and works well and is very safe. The last summary item that I have is, we could provide more oral pain meds for minor or moderate illness and injury. So, we could be more aggressive in dosing patients with ibuprofen or Tylenol, particularly patients with relatively minor orthopedic injuries that are uncomfortable. Not every patient with an ankle injury requires an opioid or ketamine. So we could think about using PO pain meds in the field for those minor to moderate injuries. And as I mentioned, if you give it to the patient in the field, that's at least 30 minutes faster than if they wait to get it in the emergency department. So you can do something about pain. That's it for the month. Thank you. If you have an interest in seeing the article that I've talked about, feel free to reach out to me at this email address, and I'd be glad to send it to you. And if you haven't already, make note, this is my new email address through the ARCOG. You can reach out to me at any time this way, or you can send me a query via Basecamp. So that's it for March. We'll see you next month in April.